Hello, today I'm going to be talking about atypical lobular hyperplasia. So what is atypical lobular hyperplasia? Atypical lobular hyperplasia is an accumulation of abnormal cell in one or more lobule in the breast. It is a high-risk benign lesion classified as being premalignant, which means it has the potential of becoming breast cancer. Usually women are asymptomatic, so there are no known signs or symptoms. ALH is an incidental finding and will most likely be discovered during a breast biopsy. Typically, this disease occurs bilaterally. In the diagram, you can see a duct and a lobe. Beneath that, you see a normal duct, and then a hyperplasia duct, which is an increased amount of cells, and then the atypical hyperplasia, which is the accumulation of abnormal cells. And then below that is the ductal carcinoma, and then finally the invasive breast cancer. Histology. There are two types of atypical hyperplasia. The first is a typical lobular hyperplasia, as mentioned before, is an overgrowth of abnormal-looking cells in one or more lobe. The second is atypical ductal hyperplasia, which is an overgrowth of abnormal cells in the lining of the breast duct, the tube that carries milk from the lobules to the nipple. Both conditions carry an equal amount of risk for developing into cancer. What characterizes ALH is that acini of the lobular unit expand less than 50% of the lobular unit and are filled with small, monotonous, round or polygonal cell. The lobule lacks cohesion in structure and loses their acini lumens, which is a round space within the acini, or the acini. If you look at figure A, you'll see a healthy lobule with a cohesive structure. Figure B is an ALH sample showing lack of cohesive structure. Diagnosis. ALH may or may not appear on a mammogram because of its size. When apparent in a mammogram, usually through a routine screening, it can appear as a cluster of microcalcifications, which are small white densities. Ultrasound can also be used to detect microcalcifications, but it may not present them as well as the mammogram. For some women with dense breast or with a history of cancer, MRI is used. Ultimately, ALH is discovered in 10% of all biopsies. The sample is sent to the pathologist for an accurate diagnosis. The cause of ALH is unknown, but it is found in women in their 40s and it is a rare occurrence in men. Treatment. Sometimes a lumpectomy is performed to further evaluate AHL or to remove abnormal cells if the biopsy detects other abnormalities. Generally, a follow-up physical exam is done at 6 months with a possible mammogram. Preventative medication can be given to reduce the risk of breast cancer, such as tamoxifen or raloxifene, which block estrogen receptors. Estrogen is thought to increase the growth of breast cancer. The medication is prescribed for up to 5 years. Women are told to avoid hormone therapy, which increases estrogen. Women at an increased risk can elect to have a prophylactic mastectomy, which can reduce the risk by up to 97%. Survival rates. Cumulative incident data is preferred when counseling women in regards to breast cancer risks. The data shows that 5 years of diagnosis, 7% of women develop cancer. At 10 years, 13% develop cancer. At 25 years, 30% develop cancer. Chances are greater of developing cancer if diagnosed before the age of 45. The overall lifetime risk for developing cancer is 30%. Women diagnosed with the disease are 4 times greater for developing cancer than women without AHL. According to the Mayo Clinic, among 698 women with atypical hyperplasia, the women with atypical lobular hyperplasia who developed cancer, 77% was ductal cancer and 23% was lobular cancers. So even though atypical lobular hyperplasia is a benign lesion, it must be monitored closely. This concludes my presentation. Thank you for listening.